fascinating anomalies, the sinus and the fistula. So get ready to think like a surgeon as we decode the incredible clues the human body leaves right out in the open.
Here is our roadmap for today's investigation. We'll start with the surgical mystery itself, then look at the anatomy of these tracts, move on to the clinical interrogation, figure out why they won't heal, and finally, open up some real case files. Let's get to it.
Section 1. The Surgical Mystery, Surface Clues to Hidden Pathology.
So, to solve this mystery, we've got to get our terms straight right off the bat. What exactly are we looking at? Well, think of a sinus like a blind alley. It's basically a tract that leads down from the surface of your skin into the tissues, but it just hits a dead end. There is only one opening. Now, a fistula, on the other hand, is totally different. It's essentially an abnormal tunnel. It's a communication that connects the lumen of one hollow organ to another, or it connects a hollow organ directly to the outside of your body.
Moving on to Section 2. Anatomy of the tracts. Internal versus external.
Okay, so fistulas are generally split into two main categories, internal and external. An internal fistula connects two internal hollow spaces together. Imagine your windpipe accidentally connecting to your food pipe, or your colon to your bladder. Nasty stuff, right? In these cases, you wouldn't actually see an open wound on the skin, but you'd absolutely have some severe internal symptoms. External symptoms. External fistulas, though, bring those internal problems right out to the skin's surface. We're talking about things like an orocutaneous fistula, connecting the mouth cavity to the cheek skin, or congenital ones you might have heard of, like branchial and thyroglossal fistulas.
Section 3. The clinical interrogation, taking the history.
Just like a detective taking the stand, the clinical history-taking phase is where the real investigation begins. One of the absolute first questions a clinician is going to ask is, did you undergo any surgical procedures or trauma? Why? Because retained foreign bodies are a massive culprit for acquired sinuses. Actually, in surgical wards, something called a stitch granuloma is incredibly common. It's basically an infected sinus tract caused entirely by a tiny piece of suture material accidentally left behind after an operation.
The next big question in our interrogation is, what is the color and nature of the discharge? You see, these tracts almost never stay dry, and the fluid weeping from that opening, it's honestly one of the most telling pieces of evidence a clinician can gather. It's like a direct message being sent up from the hidden pathology below.
Now, what's really interesting here is how the sensory details of that discharge point us directly to our prime suspects. If it's just clear, serous fluid, you're usually looking at no active infection. But if that discharge is thick, white, and kind of cheesy, a detective immediately suspects tuberculosis. What if there's a really foul smell? Well, that points straight to mixed infections from anaerobic bacteria hiding deep down in the tissues. Yellow granules? That suggests actinomycosis. And, get this, if there are tiny bony spicules weeping out of the wound, that means the underlying bone itself is actually infected and literally crumbling away. A really serious condition called osteomyelitis. Okay, so moving from the discharge to just purely looking at the wound, the actual physical location of the opening gives away the diagnosis in the vast majority of cases. It's pretty wild. A sinus right on the point of your chin, that is almost certainly a median mental sinus. An opening on the side of the neck, right along the sternomastoid muscle, is classically a branchial fistula. If it's right in the middle of a neck, boom, thyroglossal fistula. And a persistent opening in the right lower abdomen, the right iliac fossa, could totally point to an appendicular fistula. Location literally is everything here.
After just looking, the surgeon has to use their hands. Palpation is absolutely critical. They're feeling the tissue around that opening for two specific things: induration, which is basically an unnatural hardness, and fixity. So, for example, if the surgeon wiggles the tissue around a sinus and it feels totally tethered, like it's glued to the underlying bone of the jaw, that strongly suggests osteomyelitis. On the flip side, a sinus caused by tuberculosis will typically lack that hard induration entirely. It'll feel completely different.
Check out this X-ray, because it brilliantly shows just how deep this investigation really has to go. This is a diabetic patient with a persistent sinus on their big toe. But looking beneath the surface reveals the true culprit, a sequestrum, which is a piece of dead bone caused by osteomyelitis. That surface sinus, it's really just an escape hatch for the nasty infection deep inside.
Section 4. Why won't they heal? The suspect liner. So let's line up the usual clinical suspects. Why do these things just refuse to close up? Well, a tract is going to remain stubbornly open if there's a foreign body trapped inside, or a specific persistent infection like TB.
It definitely won't heal if there's a distal obstruction blocking the normal flow of internal fluids, because those fluids are just forced out through the skin instead. Malignancy or cancer is another one that can keep it wide open. Oh, and here's the crazy one: epithelialization. That's where skin cells literally grow down into the tract and line the whole thing, creating a permanent, built-in tunnel. And honestly, until the surgical detective goes in and removes these root causes, that tract is just not going to close.
Section 5. Opening the case files. Clinical examples.
All right, let's open up case file number 1, the median mental sinus. Take a look at this discharging wound situated right on the symphysis menti, basically the exact center of the chin. A patient comes in complaining of this recurring swelling right there that bursts, drains some fluid, seems like it's healing, and then just comes right back. But here is the brilliant plot twist. You'd probably think the problem is just a stubborn skin infection on the chin, right? Nope. A median mental sinus is actually caused by a badly decayed tooth. Specifically, we're talking about an apical abscess way down at the root of the lower incisor teeth. The pus from that bad tooth literally melts its way down through the jawbone, slips underneath the facial muscles, and just erupts right through the skin of the chin. It's wild. If a doctor just treats the chin, it's never going to heal. You have to go in and extract that bad tooth.
Now let's move over to the neck. Remember our rule about location? A thyroglossal fistula sits squarely in the midline of the neck, period. Conversely, a branchial fistula is situated laterally, over on the sides of the neck. So just by observing if it's midline versus lateral, a clinician can instantly differentiate between these two major congenital issues.
And the physical exam gives us even more functional clues. For a thyroglossal fistula, which is actually tied to the developmental path of the thyroid gland, the surgeon will just ask the patient to stick their tongue out. Because the tract is literally connected to the base of the tongue, the fistulous opening will actually move upward when the tongue protrudes. It also often features a hood sign, which is just a little fold of skin over the opening. Now, a branchial fistula, on the other hand, is a remnant of embryonic gills, the second branchial cleft to be exact, and that one will always sit laterally on the lower third of the sternomastoid muscle.
Our final case file is a pretty severe acquired condition. It's a carcinoma of the cheek that's resulted in an oral cutaneous fistula. What happened here is a malignancy inside the oral cavity aggressively infiltrated outward. It just ate right through the tissues until it breached the skin. This creates a direct, completely abnormal communication between the inside of the mouth and the exterior of the face. It perfectly illustrates how malignancy is a massive cause of persistent fistulas.
You know, the source text for our explainer today features this incredible anecdote about a patient with a chin sinus. This poor guy endured multiple failed surgeries by practitioners who simply didn't know to check his teeth. The text summarizes it with this really powerful quote: "What the mind does not know, eyes cannot see." I mean, that perfectly encapsulates why having this structured medical knowledge is so incredibly crucial. Because if you don't know the underlying pathology, you're only ever going to treat the surface.
And that officially wraps up our investigation. We've traced the tracks from internal cavities right out to the surface skin, we've interrogated the clues hiding in the discharge, and we've finally uncovered exactly why these stubborn wounds refuse to heal. So I'll leave you with this. Next time you see a surface wound, are you just going to see a simple scrape, or are you going to start looking for the hidden sinus or fistula tract beneath? Keep thinking like a detective, and I'll catch you in the next explainer.